Hi, welcome to Dr. Vic's Academy. Today we will be talking about urinary stone disease, presentation and diagnosis. The classic presentation of renal colic is excruciating unilateral flank or lower abdominal pain of sudden onset that is not related to any precipitating event, and is not relieved by postural changes, or non-narcotic medications. There may be associated nausea and vomiting. The pain of renal colic often begins as vague flank pain which then evolves into waves of severe pain. It is generally believed that a stone must at least partially obstruct the ureter to cause pain. As the stone progresses down the ureter, the pain tends to migrate caudally and medially. Distal ureteral stones may be manifested by bladder instability, urinary frequency, dysuria or pain radiating to the tip of the penis, or the labia or vulva. Gross or microscopic hematuria occurs in the majority of patients presenting with symptomatic nephrolithiasis. It can also be present in asymptomatic patients. The absence of hematuria in the setting of acute flank pain does not exclude the presence of nephrolithiasis, as hematuria is not detected in 10 to 30% of patients with documented nephrolithiasis. Differential diagnosis. Symptoms similar to those of renal colic can be caused by non-calculous conditions. In women, gynecologic processes that must be considered include ovarian torsion, ovarian cyst and ectopic pregnancy. In men, symptoms of testicular processes, such as a tumor, epididymitis or prostatitis, may mimic the symptoms of distal ureteral stones. Other general causes of abdominal pain, such as appendicitis, cholecystitis, diverticulitis, colitis, constipation, hernias or even arterial aneurysms, may elicit similar discomfort. Urinalysis. Urinalysis findings consistent with urolithiasis include hematuria and limited pyuria. Other findings include the urine pH and the presence of crystals, which may help to identify the stone composition. Patients with uric acid stones usually present with acidic urine. Those with stone formation resulting from infection have an alkaline urine. Limited pyuria is a fairly common response to irritation caused by a stone. In absence of bacteria, is not generally indicative of coexistent urinary tract infection. Therefore urine culture should be routinely performed. Diagnostic imaging. Diagnostic imaging is essential to confirm or exclude the presence of urinary calculi. A non-contrast helical CT can detect both stones and urinary tract obstruction, and has become the gold standard for the radiological diagnosis of stone disease. Of currently available imaging techniques, non-contrast helical CT has the highest sensitivity and specificity for the identification of urinary tract stones. This imaging modality is fast and accurate, and it readily identifies all stone types in all locations. Its sensitivity at 95 to 100%, and specificity at 94 to 96% suggest that it may definitively exclude stones in patients with abdominal pain. In addition, it can detect the degree of ureteral obstruction, as well as distinguish cystine and uric acid stones from calcium stones. Less frequently used tests. Radiological tests that are less frequently used include ultrasonography, plain X-ray, intravenous pyrography, and magnetic resonance imaging. Some of these tests are used in the initial diagnosis of nephrolithiasis only if CT is unavailable. Abdominal ultrasonography. Abdominal ultrasonography is the procedure of choice for patients who should avoid radiation, including pregnant women and possibly women of childbearing age. However, it has limited use in the diagnosis and management of urolithiasis. Its sensitivity to ureteral stones is only 19%. However, if a ureteral stone is visualized by ultrasound, the finding is reliable, with specificity at 97%. The ultrasound examination is highly sensitive to hydronephrosis, which may be a manifestation of ureteral obstruction. Plain film radiography. Plain film radiography of the kidneys, ureters and bladder, or KUB, may be sufficient to document the size and location of radiopaque urinary calculi. Stones that contain calcium, such as calcium oxalate and calcium phosphate stones, are easiest to detect by radiography. Less radiopaque calculi, such as pure uric acid stones and stones composed mainly of cysteine or magnesium ammonium phosphate, may be difficult to detect on plain film radiographs. Although 90% of urinary calculi have historically been considered to be radiopaque, their sensitivity and specificity of KUB radiography alone remain poor, with sensitivity at 45 to 59% and specificity at 71 to 77%. KUB radiographs are typically useful in the initial evaluation of patients with known stone disease, and in following the course of patients with known radiopaque stones. Interventional therapeutic modalities. Renal calculi less than 2 cm in size can generally be treated with extracorporeal shockwave lithotripsy. Extracorporeal shockwave lithotripsy is also effective for ureteral stones, with an upper size limit of approximately 1 cm. Unknown ovarian effects are the basis for a relative contraindication to the use of extracorporeal shockwave lithotripsy in women of childbearing age who have middle or distal ureteral stones. Percutaneous nephrolithotomy remains a safe and reliable method of removing large renal and proximal ureteral stones. Advances in ureteroscopic techniques now allow calculi that are not good candidates for extracorporeal shockwave lithotripsy or percutaneous nephrolithotomy to be treated virtually anywhere within the ureter or kidney. Preventing future stones. Calcium oxalate stones are the most frequent stones, and are usually idiopathic and associated with hypercalciuria, hyperuricuria, and hypercitraturia. Recommended preventive measures that one may consider include restricted intake of animal protein and salt. Uric acid stones are usually associated with acidic urine, and in conjunction with massively increased urinary uric acid secretion. Hence alkalinization of urine with bicarbonate or citrate, in combination with allopurinol, may be considered. In summary, diagnosis of renal colic cannot be based on the clinical findings alone. The application of non-contrast helical CT is the gold standard in the radiological imaging of urinary stones. Management is based on recognition of emergency requirements for urological consultation. The provision of effective pain control using a combination of narcotics and non-steroidal anti-inflammatory drugs in appropriate patients. And an understanding of the impact of stone location and size on natural history, and definitive urological management.
Audio Jungle. Audio Jungle.